In early 2014, the University of Virginia Health System has introduced two new tools to improve the safety of the patients we serve: the Emergency Airway Team and the Emergency Surgical Airway Kit. This presentation will cover three topics. 1. The Emergency Airway Team, how to activate the team, what to expect from a response, and team composition and responsibilities. 2. The Emergency Surgical Airway Kit, where they are located, what the kits contain, and a few clinical considerations about the contents. And 3. How to incorporate this new kit into the daily emergency equipment checks. It is important to note that not all areas will have a kit. However, all areas are covered by the team. When faced with a clinical situation where an airway may require a surgical approach, call 42012 and ask for the Emergency Airway Team. Any clinician can initiate this emergency asset. This is a silent group page with representatives from anesthesia, ENT, emergency general surgery, the surgical IRPA, and respiratory therapy. When the page is sent, the team will respond, and respiratory therapy owns the responsibility of ensuring that the emergency surgical airway kit arrives at the bedside. This does not mean that respiratory therapy is the only service who can bring the kit to the bedside, just that they are responsible for ensuring that that task is completed. Clinical situations that start as or lead to can't intubate, can't ventilate scenarios are numerous. These are a few examples of situations where the emergency airway team would be of value to the patient. ENT patients with expanding neck hematomas, trauma patients with facial fractures and/or copious oral bleeding, burn patients requiring an initial or a repeat advanced airway, such as patients who self-extubate and have developing oral edema, and morbidly obese patients with traumatic self-removal of tracheostomy. Self-removal of tracheostomy can happen anywhere, either in the ICU or acute care, and depending on a number of variables can quickly deteriorate. If you believe that your patient may require more than a standard oral intubation, call 42012 and request the Emergency Airway Team. This emergency process was designed differently than other emergency assets. The kits are located in each ICU, the emergency department, PACU, and PICU for use anywhere in the main hospital. Again, respiratory therapy has the responsibility of making sure the kit arrives at the bedside when the emergency airway team has been paged. Any clinician can retrieve the kit, but respiratory therapy will ensure that task has been completed. Here is the Emergency Surgical Airway Kit. It is readily identifiable by the two signs and the aesthetically pleasing lavender color. The expiration date up top reflects the first expiring item in the box, and the seal will be found here. The packing list has the box contents listed if you ever needed a quick reference. Opening the top of the Emergency Surgical Airway Kit, in the top tray clinicians will find a ChloraPrep cleansing sponge, a number 10 disposable scalpel, one medium curved Kelly clamp, one tissue spreader, one Wheatlander retractor, one tracheal hook, and single-use packets of Surgilube. Removing the top tray of the Emergency Surgical Airway Kit, you will find a 14 French gastric tube that is paired with a number 4 Shiley, an 18 French gastric tube that is paired with a number 6 Shiley along with a bougie. The gastric tube and bougie are part of the kit if a Seldergan technique is chosen to place an airway. Also a 6.5 endotracheal tube, one multi-pack of 4x4s, and for securing the airway, a choice of a suture pack with a straight needle or a single length of twill tape. While this video is not intended to be used as instruction on performing a surgical airway, we did want to convey the purpose of some of the instruments for those physicians performing the surgical airway and for those clinicians assisting in the process so that they may anticipate the potential needs of the physicians. We chose a tissue spreader for exposing openings in tissue, a tracheal hook for grasping the trachea if needed, Kelly clamps for multiple uses, and a Wheatlander retractor for holding open soft tissue. Note that the medium sharp Wheatlander retractor was chosen as opposed to the dull version. Shown here is the 14 French gastric tube coupled with the number 4 Shiley and the 18 French gastric tube coupled with the number 6 Shiley along with the bougie and packets of lubricant. When choosing the guide wire or Seldinger approach with either the gastric tubes or bougie, lubricant should be used with caution to not make a challenging situation worse with too much lubricant. Please remember that this presentation is not intended to be instruction on performing surgical airways, but an overview of the tools provided in the kit. For more information on this technique, go to the Medical Emergency Response website and view the article, A Novel Method for Replacement of the Dislodged Tracheostomy Tube, the Nasogastric Tube Guide Wire Technique. For nursing staff in the Adult Intensive Care Units, PICU, PACU, and Emergency Department, the Emergency Surgical Airway Kit will need to be incorporated into the daily emergency equipment checks. The customizable addendum form is the correct place to add this kit. To retrieve this form, go through the clinical portal, Forms and Policies, and find 0802B, Code Cart and Operational Equipment Check Sheet, Customizable Addendum. The correct form should look like this, and remember that this is Sheet 1 with days 1 through 16, and Sheet 2 has days 17 through 31. After saving the form, you can type in Emergency Surgical Airway Kit, and for those ICUs that have more than one kit, you can type this twice, and any other additional customizable emergency equipment that you have in your unit. On behalf of the Medical Emergency Response Subcommittee, thank you for taking the time to view this presentation on this initiative to improve the safety of the patients we serve. For more information, please contact Bill Brady, MD, or John Gilday, RN. Thank you.